Great. So good afternoon. Thank you all so much for joining us today on our webinar. We are being joined by a really great group of speakers, of women, today for this particular webinar series. My name is Marissa Tonelli, and I am the Senior Capacity Building Manager at Health HIV. And we're putting on this webinar series as part of our Leadership Link and Learn series, Health HIV's ASO CBO Leadership Initiative. So this webinar is going to be about an hour long. We have 4 very dynamic speakers with a lot to say, and so if we go over a little bit, we hope you can continue to join us, and if not, this webinar will be available on our website recorded after today's session. So I just wanted to take a moment to introduce Health HIV. We have 4 core capabilities: capacity building, health services research and evaluation, advocacy, and education and training. And primarily our capacity building programs right now have focused with AIDS service organizations, community health centers, health departments, and healthcare providers. And so today we're doing a capacity building effort primarily focused towards individuals that are interested in leadership, particularly in the African American female community. And we have some great speakers again here today to talk about what approaches are being done right now and how we can engage. I do hear an echo on the line, so if anyone that is accessing this line on your phone or on your computer, if you would please mute, and I will do my best to make sure everyone is muted without muting our speakers. If our speakers could please ensure your computer or your phone are on mute, we would very much appreciate it. Thank you. So I mentioned our capacity building programs, and the slides, I'll show where you can download the slides, so I won't go through this much, but we do have capacity building programs focused on a variety of different areas, and you can find out more on Health HIV's website. Our 3D program, which is what we are delivering this particular AIDS service organization and community-based organization capacity building under, works with communities and organizations to facilitate community infrastructure development and systems coordination, promote workforce development, including training the next generation of leaders, expand care team integration through partnership development, demonstrate cost effectiveness and outcomes monitoring of programs to maximize strengths, develop systems to improve linkage and retention, and diversify fundings of organizations to enhance sustainability. And those are just some of our activities. And as I mentioned, we're promoting this particular webinar series, our Leadership Link and Learn webinar series, as part of Health HIV's AIDS service organization and community-based organization leadership initiative. And we have several pieces for this particular training and certificate program, and this is just one of our activities. Our other activity is an online 6-module ASO Leadership Initiative training and certificate program. You can use the link here to access it, and again, the slides will be available, and you can also go to Health HIV's website to access it. So you may download a guide to our leadership program at the URL, and also available today is the slide deck. The bottom right of your screen, there is a little document folder. If you click on that, you can direct download a PDF of the slides. We will also post the webinar recording, and any question and answer that is available or occurs following this particular webinar will also be posted and available online. If you have any questions, comments, there is a chat box in the bottom left screen. You can type your message in. If you have a question for the presenters or if you have a question for any other attendees, it is visible to all attendees, so you know. And please feel free to utilize that at any time during the course of this presentation. Again, somebody's asking about the copy of the slides. please use the bottom right of your screen. There's a document folder. You can click on it and download it. And I'll demonstrate how to do that again at the end. So I introduced myself today. Again, my name is Marissa Tonelli. I'm the Senior Capacity Building Manager at Health HIV. And I'm very pleased, again, as I mentioned, to have a great group of women today here to talk about this particular issue of HIV in the community, the heterosexual Black female community. And so we have a really great group. I'm pleased to have Lady Karan Sadler, Reverend Sadler, on as well. Reverend Sadler is an advocate and public figure. She serves on several boards and has really assisted me in pulling together this really great presentation for us today and group of women to serve. She also serves as chaplain at one of the nation's leading trauma hospitals and works with those who are struggling with identity and or self-esteem issues, depression, suicide, HIV/AIDS, and other life-altering issues. So I'm going to introduce Reverend Sadler to introduce our next speakers and facilitate part of the meeting. So Reverend Sadler, thank you so much for joining us, and I will let you take over from here.
To Health HIV, I'm excited to be a part of this call, and we're going to go ahead and get started. Our very first speaker is going to be Shondell Wilson Frederick, Dr. Shondell Wilson Frederick. And before I actually introduce her, I just wanted to lay a foundation for today's webinar, just to provide some context on the title in which we derived at. Oftentimes, African American women specifically are often left out of a lot of conversations as it relates to HIV and AIDS, whether you have contracted HIV or whether you're living a life or you're in a position to potentially contract HIV. So today's webinar is going to definitely focus on African American women. While we know that there are several women of various ethnicities that are living or in positions to contract HIV, and that specifically, women of color are in positions to contract HIV. I think it's very important today that we focus on Black women or African American women to highlight and to allow us to learn ways that we can better assist those that are living in the community nationally or in the communities in which we serve, to better help them and to help prevent them from contracting HIV. So again, today we want to focus on Black women and or African American women as we have this dialogue. And the panel consists of African American women who are going to be able to speak to the issues that we're going to address as it relates to HIV and AIDS. So our first speaker, again, is Dr. Shondell Wilson Frederick, who is a statistician in the Office of Minority Health at the Centers for Medicare and Medicaid Services, known as CMS. In addition to providing leadership, vision, and direction to advance the HHS and CMS strategic plan, Dr. Wilson Frederick is responsible for developing an agency-wide data collection infrastructure for minority health activities and initiatives, as well as developing and implementing statistically reliable methods and strategies to merge survey data with administrative and utilization data. Dr. Wilson Frederick is a lieutenant in the Commission Corps of the U.S. Public Health Service, and we are glad to have her on the phone. And to prevent us from delaying this phenomenal webinar, we're going to go ahead and have her to begin speaking. Dr. Frederick.
Great. Thank you for that kind introduction. So the title of my presentation this afternoon is Using the Mapping Medicare Disparities Tool to Examine Health Disparities in Black Females. On the next slide, I provide an overview for my presentation. I'll discuss the mission of the CMS Office of Minority Health, provide some understanding of Medicare eligibility and claims data, also discuss the first ever CMS Equity Plan for Medicare, and describe how the Mapping Medicare Disparities Tool can be used to examine health disparities in Black females. So on the next slide, it shows that the Affordable Care Act requires the establishment of offices of minority health within 6 agencies in the U.S. Department of Health and Human Services. These offices join the existing HHS Office of Minority Health and the National Institute on Minority Health and Health Disparities at the NIH to lead and coordinate activities that improve the health of racial and ethnic minority populations. On the next slide, I describe the CMS OMH functional objectives. Those include coordinating minority health initiatives within CMS. We serve as a liaison between CMS, the HHS Office of Minority Health, and other agency-level offices of minority health. We also participate in developing CMS policies, regulations, plans, and programs to ensure that minority health interests are represented. And finally, we serve as a resource to other CMS components. On the next slide, I describe Medicare eligibility and claims data. So what is Medicare? Medicare is a federal health insurance program for people who are 65 years old or older, also for certain younger people with disabilities, and for people with end-stage renal disease known as ESRD. CMS data are health services utilization data, also known as claims data, that are derived from reimbursement information or the payment of bills. On the next slide, I describe the strengths of using claims data. These include that claims data are clinically valid, and for this reason, claims data are a very useful resource for health disparities research. They also include demographic data, such as age, race, ethnicity, place of residence, and date of death. And finally, claims data can be linked to other useful data sources, such as data from the U.S. Census Bureau or data from the National Death Index. So the next part of our presentation will focus on the CMS Equity Plan for Improving Quality in Medicare. This plan consists of 6 priority areas, and it was released in 2015. And as I said in my introduction, this is the first time that CMS has ever released an equity plan for Medicare. This is a 4-year strategic plan, and it identifies multi-level solutions to reduce disparities in Medicare. And this afternoon, I'm going to focus on priority 1, which is expanding the collection and reporting and analysis of standardized data. So on the next slide, I provide an overview of the Mapping Medicare Disparities tool, also known as the MMD tool. This was one of the first products of the CMS Equity Plan, and this tool was released in March 2016. The MMD is populated with aggregated county and state level data from 2012 through 2014 CMS 100% fee-for-service administrative claims. Populations include Medicare beneficiaries who are 65 years and over, less than 65 years with disabilities, and persons with end-stage renal disease. The MMD contains measures for disease prevalence, costs, and hospitalizations for 18 specific chronic conditions, emergency department utilization, readmission rates, mortality, and preventable hospitalization. These measures can be viewed by race, ethnicity, and/or sex using county and state level Federal Information Processing Standard codes. The next 6 figures that I'll be showing examine chronic conditions among Black females who are dual and non-dually eligible for Medicare. So on the next slide, figure 1 shows the national profile of depression among Black and white females who are dually eligible for both Medicare and Medicaid. Also, for non-dual Medicare beneficiaries in 2014. The gray area on the map for females indicates insufficient data. The higher prevalence of depression is shown by the darker shade of blue on each map. Let's look more closely at Black-white disparities in depression at the county level among females in California. On figure 2, the next slide, by hovering over Los Angeles County in California, a pop-up box appears showing the within-county Black-white disparities. The prevalence of depression in Black females is 6 percentage points higher than white females in Los Angeles County. On figure 3, the next slide, shows the state-level prevalence of heart failure among Black female dual and non-dual Medicare beneficiaries. Remember, the darker shade of blue indicates a higher disease prevalence. For example, Louisiana is dark blue, meaning that Black females in Louisiana have a higher prevalence of heart failure. So let's investigate this further. Next slide. As shown on figure 4, we can click on the download button, which is circled in red, and download the data to examine specific county-level prevalence estimates for all states. This table shows that Catahoula and Concordia counties in Louisiana have the highest prevalence of heart failure among Black female dual and non-dual Medicare beneficiaries in 2014. Additionally, you can then use your mouse and hover over each county in Louisiana. By doing this, it is revealed that these two counties are actually physically next to one another, and this can be really helpful in developing targeted interventions, perhaps for local health departments in those two counties. So on the next slide, let's say you live in Pennsylvania and you're interested in knowing which Pennsylvania county has the highest Black-white difference from the state average among females, with heart failure. As shown in figure 5, among female dual and non-dual Medicare beneficiaries, Armstrong County has the highest Black-white difference at 33% in 2014. So in the final figure, we examined county-level Black-white differences in ED visits for female dual and non-dual Medicare beneficiaries with 3 or more chronic conditions. You see more darker shades of blue in California and in the South, as well as along the East Coast. The darker the blue, the greater rate of emergency room visits for Black females compared to white. So in conclusion, the MMD tool can help to identify geographic disparities in chronic disease by sex, age, race, and ethnicity, and dual eligibility. The MMD tool is an important step to inform policy decisions that advance health equity. The MMD tool can easily be found by Googling CMS MMD tool.
Great,
and the final slide just provides my contact information.
Our next presenter
Thank you.
is going to be Dr. Bambi Gaddis. And Dr. Bambi Gaddis, I would like to introduce you real quick. I know what you.
And I'm sure hoping you can hear
Dr.
me.
Bambi Gaddis is a co-founder and serves as executive director and principal investigator of the South Carolina HIV/AIDS Council. She has been committed the past 32 years of her professional life working in the area of human sexuality with a specific focus on HIV and AIDS as well as STDs. On a community level, mobilizing. She also focuses on behavioral intervention and research, technical assistance, capacity building, and the elimination of other health disparities. Dr. Gaddis, would you please share with us your highlights today?
Good morning, or good afternoon, rather. Let me first start by saying, as we established our platform for today's conversation, I was really compelled to begin by reaffirming this elephant in the room. It was really important that I looked at my ultimate goal as a facilitator and then asked myself what variables beyond behavior explain the continued prevalence of HIV among Black women in America. So what is it that we're missing? And after 35 years of an epidemic, how will we change our collective direction as we face turbulent political times? And we're struggling to gain access to quality health care. So how and will we take ownership, and how will Black women and our caregivers take ownership to change this course? So to my intention to discuss historic factors that go unrecognized or unspoken, despite the fact that there are significant impacts on sexual health and lives of Black women and girls. I believe that these historic realities curtail our motivation and have created a sense of paralysis, resulting in our disproportionate overrepresentation in HIV. And so I have to admit that I'm a recovering Northerner by birth, and since my early days as a student at Tuskegee University and a resident of South Carolina, one southern state since 1978, I've been quite enlightened at the differences. Now more than ever, I really want to learn from my past and set some sights on changing the future by first acknowledging my legacy and refusing to ignore realities of slavery and how trauma persists even today in the hearts and souls of Black women, especially since the South has an historic legacy of disease where the health of males and female slaves were deemed unimportant and expendable. What you'll see here in this slide depicts the realities of our passage and the historic dismantling of a people who once maintained traditions and a sense of ownership. Our transport here to the United States from Africa was filled with trauma, both societal, familial, with major impacts on our sense of individual empowerment and community organization. We did not own our own bodies. Black women were property and were not permitted to have control over their sexual health or their well-being. Black men were not permitted to protect their women, and like us, Black women, they were forced to engage in sexual acts despite their consent or marital status. It was tradition to separate Black family units to create a sense of confusion and trauma, all for the purpose of generating wealth within a slave industry. On the state grounds of South Carolina, there sits a statue of the father of modern gynecology, Mr. J. Marion Sims. His study of the female reproductive system included the development of a surgical technique which addressed severe complications of childbirth. His use of enslaved African American women as experimental subjects is considered highly unethical by modern historians and researchers. He's considered a prime example of progress in the medical profession made at the expense of a vulnerable population. And from 1845 to 1849, he experimented with over 30 slaves, operating on this one particular woman over 30 times. She had a particularly difficult combination of reproductive problems. And although anesthesia was recently available, he did not use any form of anesthesia during his procedures with her or several other key slave women. So many years later, despite what was reported about the scientific outcomes of Mr. Sims' research, we continued to deal with the implications of the Tuskegee studies, which many of you have heard of. And that experiment on over 600 men who were told that they had bad blood, if you will, occurred which it was originally to begin for a 6-month period, but ended up lasting for 40 years, actually up until the date of 1972. So the growing epidemic of HIV, even among young Black girls, is propelled by our national commitment to censor life-saving information within public schools and communities. Several years ago, SCAHEC, our agency, the South Carolina HIV/AIDS Council, conducted qualitative and quantitative focus groups with adolescent Black girls 14.
Please bear with us as we reconnect Dr. Gaddis. We apologize. Bear with us, please. And and before, okay. And as abs, yes. Can everyone hear me? sorry, what'd you say?
How much time are you gonna need?
Oh, to 1:30. Did you need to come back in?
Yeah, we were starting back at 1:15.
Okay, I can move. I can move. They're having, they are, they're actually having difficulties and so, yeah, they are, so it's horrible. So
So were you here to be closer to the router or?
his phone didn't have, but I could just sit in the hallway. That should be fine. As long as he don't mind me taking his phone.
All right, we've got a few more minutes, so.
Well, I want to go ahead and get transitioned because I
Okay.
have to introduce the next speaker.
Okay.
So yeah, they can come on in. I'm on mute.
We should.
These are dynamic speakers, and this is horrible, but this is not.
This is a webinar for, I know you said that you would hope we would be there for 1 o'clock.
I was contracted to organize a webinar, so this is about Black women and HIV and the social determinants that are affected to it.
Okay.
Oh, I know, working, multitasking.
Yes. Well, I wanted to, early on when you were speaking and you were asking some questions about how to do it, one of the things, and one thing that came up here was about older members and, well, not so much older members, the congregation and their minds. Oh, she's
still on the call.
Oh,
Let's
oh,
move her around.
oh, okay. Thank you for telling me.
That's okay, that's okay. I was trying to multitask.
No, we need to know that.
The only thing is if I move in the hallway, I'm gonna need some quiet.
Yeah, could you ask people to be quiet there and then they can come in here?
Okay.
It goes to 1:30. Was that office didn't work? The only reason I'm saying is we have the tester coming, so I want to prepare them. That's why I told them 1:15 back here. The tester's coming. Okay. Yeah, I was trying to see if I could accommodate you. That's why I was indicating.
Don't rearrange your schedule for mine.
All right.
Yeah, you can come in. We just need to be quiet. She's finishing up a call.
I'm not gonna go to your schedule.